contentious subject of uveitis. Sure, the residents who are attending this meeting would have heard about the challenges that we face when we are dealing with uveitis. When you are diagnosing tuberculosis in the lung, for instance, you depend upon a direct evidence of, say, demonstrating the AFB on a sputum smear, or else you would have some extrapulmonary tuberculosis patients where a tissue might be available for doing histopathology, and you can demonstrate the pathology. On the other hand, in the eye, it's almost impossible to demonstrate the presence of AFB. Doing biopsies from the choroid or retina is a major invasive procedure and hardly ever done. So we often depend upon, for making this diagnosis of TB uveitis based on some corroborative evidence, based on radiological or immunological investigations. The challenge with the immunological test is that what's the basis first? The test, both the skin test or Montu that you're aware, or the quantiferon test, they both depend on the release of interferon gamma by the sensitized, the TB specific T cells, either in the skin when you're doing a Montu's test, or in a test tube using ELISA, you measure the quantum of interferon gamma released by these sensitized T cells which are present in the peripheral blood of the patient. These tests essentially tell us that the infection has been there in the past, but they do not tell us whether the patient has currently the disease. So they are indicative of infection, but not the disease. People say and believe that quantiferon test is a little more specific because the antigen that we use, ESAP6 or CFP10, typically the TB antigen that are used to stimulate these T cells in the test tube, they are more specific and they do not have cross-reactivity with environmental non-tuberculous mycobacteria or Mycobacterium bovis, like the tuberculin, the food extract that we use, the old tuberculin that we use for PPD, purified protein derivatives from the TB, it cross-reacts with these other mycobacteria. So you have patients who may show false positive or false negative results. So these are really not very conclusive of the presence of uveitis. The other investigation we often depend upon is the radiological investigation by an X-ray chest or a CT chest or a PET scan. These also have limitations, but like an X-ray chest or almost a quarter of these patients may show some P lesions. It will be exceptional case of TB uveitis who will have the active lung tuberculosis at the time when they present to you. Well, there have been cases where anecdotal reports where CT tests have been used to diagnose or help in diagnosing uveitis. In particular, one of the series from Chennai, when you are looking specifically at granulomatous uveitis, and I'm not doing the details of what granulomatous uveitis, I'm sure you are aware, they found that while HRCT was positive findings in almost 80% of the patients who had tubercular radiology versus about less than 10% for sarcoidosis. In the past, and there have been a few studies where they have shown very expensive test in the form of PET scan, PET CT, which might identify lesions for biopsy and show that the patient does have TB infection. Some years ago, we looked at in our own set of patients, and we found of whom we suspected clinically to be strongly suggestive of TB uveitis, that nearly half of these revealed lymph nodes in the chest, which were sub-centimetric, which could not be biopsied for confirming the presence of TB pathology in these nodes. Of the remaining, again, nearly half, I would say roughly half, had lesions which were suggestive of some old pathology. They were basically scarred lymph nodes. They did not reveal, the active TB granuloma. So only in about, say, quarter of these patients, when we did the lung biopsy using even very sophisticated techniques like EBUS, that is the endoscopic ultrasound guided transbronchial lymph node aspiration with a fine needle, we found that, well, this was positive, or from other lymph nodes that were available. Interestingly, we found nearly 12 of these patients, or 21 patients with the biopsy was positive, also demonstrated the presence of AFB, indicating that these patients did have extrapulmonary tuberculosis. So in about a quarter of these patients of clinically strongly suspected TB uveitis had evidence of extrapulmonary tuberculosis. Now, a long time back, almost in fact more than 30 years ago, we started the ball rolling of TB uveitis. When the world was silent, people didn't believe that there was anything like TB uveitis. We started exploiting this newly emerged technique of polymerase chain reaction for our patient where we clinically suspected TB uveitis. The sensitivity at that time was plus 50 plus, but we found that as we expanded our series, the sensitivity came down to almost like 1/3 of the patients only were PCR positive. Subsequent years, reports from elsewhere in this country have also shown that it's not a very highly sensitive technique. In fact, majority of the places in the world, now they do not do a PCR for diagnosing a TB uveitis. Subsequent years, we thought, well, we were earlier using the probes which were in-house prepared, that let's use some commercial techniques which are kind of automated, and you have to load the sample, and they give you a real-time PCR. You can use a gene expert, for instance, and this sensitivity again went down substantially, and so was with the line probe assay. These are not specifically designed for sampling ocular tissues or ocular fluids, but the sensitivity is rather low. The only thing we realized with these tests about 5-6 years ago was that they could discover in some of these patients the presence of the drug-resistant MPD or genome in the ocular fluids of these patients. So what I'm trying to show you here is that if we use the standard diagnostic techniques that are currently available, be it the skin test or quantiferon or radiological test or the polymerase chain reaction, individually they have all limited sensitivity. You will not be able to diagnose the case of TB uveitis if you depend individually on any of these. So it has remained a challenge, and that is why the diagnosis has always been very, very contentious and debatable all over the world. So how do we make a diagnosis of ocular TB uveitis? And now this is where we now have a consensus both in TB endemic countries or high incidence countries and countries which are non-endemic or low incidence countries like the Western world. So what we have helped define in the past 30 years has been that there is a heterogeneous way in which the TB uveitis presents, or the clinical phenotypes, how it presents. We need to be aware of those. Then specifically in people population at risk, like high incidence country like India, patients who are living with HIV or patients who are on biological therapy. Then I'm not against doing tests like skin test, immunological test, or radiological test, or PCR, or available evidence from any tissue that may be available, the lymph nodes or extrapulmonary tissues. You must avail or collect information from a variety of these sources and consult an infectious disease expert to reach a diagnosis of TB uveitis. Now, what are the clinical phenotypes? Most often, the TB uveitis presents in the posterior segment as a serpiginous-like pruritus or vitreous hemorrhage, granulomas, and less commonly adopted granuloma, neuroretinitis, or intermediate uveitis. I'll share some of the examples with you. Like this was the commonest phenotype. Nearly half of the patients of TB uveitis will present with the young people bilateral, almost bilateral, multifocal lesions of pruritus, which classically heal centrally. Now, this is what we named as multifocal serpiginous-like pruritus or tubercular serpiginous-like pruritus almost 20 years ago. And now there is a universal consensus all over the world that this is the commonest phenotype of TB uveitis, and you have to be familiar with this uveitis. These lesions heal centrally and are active so they spread centrifugally and active at the edges. These are almost always accompanied by vitritis. This is to differentiate from what people believed earlier was the classic cases of serpiginous pruritus, which was supposed to be extremely rare condition and was seen in rather elderly population, unlike the TB serpiginous-like pruritus seen in young people. And these were lesions which started in the juxtapapillary area and had finger-like projections. And these finger-like projections became active at the tip of these lesions, and it kept on progressing. As you can see here, one such patient, you can see the little bit of active, and this is going to expand here, like here, what you see, it will heal and further keep on progressing at these tips. These patients do not have any vitreous reaction, they do not show evidence of any tuberculosis in the systems, and they require, immunosuppressive therapy. And no matter what we do, these patients are destined to go blind because this leads to extensive choroidal atrophy wherever this lesion, serpentine lesions, keeps on moving around and keeps on making those areas of dead retina. Now, the other common manifestation of TB uveitis is vitreous hemorrhage. In the past, we used to call these cases an Eales disease, typically seen in young males, and you have a patient like here with vitreous hemorrhage, and like this particular instance, when it presented to me, I did a vitreous surgery to clear this vitreous hemorrhage. Patient recovered very well, 6 vision, and you can see the remnant fibrous scar tissue here along the vessels. Some of these are occluded vessels and sheath vessels, as you can see here. This patient was doing very well. I left him alone, after vitreous surgery. Video got cleared, and this patient comes back after 4 years with fresh symptoms. Now, what we find at this same eye, as you can see, now there are multifocal lesions of choroiditis or choroidal retinitis here, you can see, which on fluorescein show extensive staining here and the vasculitis. Now, what is interesting here, and this is what the point you should note, that these patients with TB vasculitis are accompanied by perivascular choroidal retinitis lesions. So this is nearly half the patients of TB retinal vasculitis will have these active or healed choroidal lesions, small lesions along the retinal vessels. Now, this patient we were interested to look at, and we found that one of his axillary nodes was accessible to lymph node biopsy that we did, and we found a TB granuloma along with AFP positivity. This patient was put on the anti-TB drug, 4-drug therapy, this is standard care, and these lesions resolved within a matter of 2 months. These lesions, the TB vasculitis, typically are segmental, and they're occlusive vasculitis. They affect primarily the retinal veins. And as you can see, this is exuberant perivascular infiltrates, a lot of hemorrhages along the vessel walls. Since they are present in the periphery, many of these patients have symptoms of like floaters, or may not have any visual complaints, and very often these patients would not present at this stage to you, and that is how you miss it. But when you do fluorescent angiography, you find that these patients have extensive capillary non-perfusion in the retinal periphery, and this will eventually lead to the formation of new vessel elsewhere in the retina, on the neovascular on the disc, which will bleed and cause vitreous hemorrhage, and that's what we used to call in the past as Ehlers disease presenting as vitreous hemorrhage. So this is a very common presentation of TB uveitis again. This has to be differentiated from sarcoid. Unlike the diffuse segmental involvement of the vessels or the veins in tuberculosis, in the sarcoid uveitis, this Candlewax nodular segmental involvement, which shows a very focal reaction, unlike what we saw, the extensive capillary non-perfusion, a lot of hemorrhages, and the perivascular infiltrates that we see along the retinal veins in the TB uveitis. The other manifestation, which is less common, but physicians are very familiar with this manifestation of TB uveitis, the parietal granuloma, typically would be seen in patients who have a disseminated disease. And you would see either a single, large, or multifocal, fewer in number, these lesions, parietal granulomas, which may present. And this is what we described a long time back. The tactile evidence of TB etiology of a parietal granuloma is the presence of this tiny intraretinal hemorrhage. If you see this one, we know that this is because of the presence of these wrap lesions or retinal vascularization with these granulomas develop. I'll come to this subject later in my talk. And these granulomas, you could have them along with retinal vasculitis, or they may be after isolated. Very often they may develop into a large abscess with the exudative retinal detachment as well. To be differentiated again from sarcoidosis, which presents with parietal granuloma, not only the nodular vasculitis, as I told you, they could present with. Now, unlike TB granuloma, these are multiple, small, and they may be associated with disc edema. There may be cystoid macular edema, but when you do an fluorescent angiography, you can see these hypofluorescent areas. On ICG, you would see the multifocal, tiny, small, little hypofluorescent or hypocyanescent lesions, which are typical of sarcoidosis. When you do Montro's test, this would be negative by and large in these patients. And in our experience, this is the biggest differentiator between a sarcoid and a TB parietal granuloma. If you do a Montro's, it will be negative in sarcoid granuloma. It will be positive in TB uveitis, but in occasionally very overwhelming disseminated TB tuberculosis, the Montro's may be negative. You have hilar lymphnopathy, almost 90-95% of the patient would show hilar gland, which are called paratracheal gland, which are swollen, and you can see these glands, and you can diagnose with great confidence the sarcoid pathology. Now, we typically treat these patients of TB uveitis once we make the diagnosis with 4 drugs. I'm not going to go into details of the conventional drug therapy, along with corticosteroids. But most of the reaction in the eye is an autoimmune reaction to the presence of TB antigen or TB bugs in the ocular tissues. Specifically, I'd like to flag the issue of the challenges that we face, and this now has been seen all over the world. A similar challenge that we flagged now nearly more than 10 years ago, and that is, once you start anti-TB drugs, some of these lesions, especially the serpiginous-like pruritus, immediately start worsening, or what we call paradoxical reaction is seen, and these lesions keep on progressing. When you do a conventional photography, we found almost like 15%, but when we extended that using ultra-wide fundus imaging tools like Optos, we found that nearly 45%, 50%, and that is the universal experience. Nearly 50% of the patients with TB subcutaneous like uveitis will show a paradoxical worsening when you start anti-TB drugs, and you certainly need to give them regular dose of oral corticosteroids. Also, we found more recently in the last 5-6 years, when we started doing gene expert and line probe assay, or we started doing gene sequencing to look for the mutations which are responsible for drug resistance in these patients. And we found that nearly 5 to 7% of these patients with uveitis may harbor genome of multi-drug resistance tuberculosis. Now that brings me to what is the direction the treatment of TB uveitis is taking, or tuberculosis in general is taking in 2022. And the recent advance has been in the last few years that now people are experimenting, there are a lot of trials going on to use the host-directed therapies, HDT, and in the coming years you will hear more about these host-directed therapies. Till now, we have known the treatment using 4 drugs which are targeted at the tubercular bacillus. Now, this bacillus goes into a dormant phase of hibernation, or what we call latent tuberculosis. And if the tubercular bug is not dividing, these therapies don't work. And typically, we need to give them for 6 to 9 months for these drugs to be effective. So now, once we understand the host cell or host cell interaction with the MTB much better than in the past, now there have been attempts to see if we can modulate the host response to the presence of MTB. And it might help us in shorten the drug therapy, it might eliminate or reduce substantially the risk of developing drug resistance. So I'd like to talk a little bit about what is happening. I'm sure you're familiar with this TB granuloma, you've read it in MBBS, and it contains epithelioid cells with a central caviation necrosis. And these epithelioid cells, multinucleated giant cells, are surrounded by a ring of TB-specific CD4 T cells, or T lymphocytes. Now, what is happening? Now, if this were happening, this is what the body is able to contain the granuloma. That is how the infection is contained. And these bugs are sitting in the macrophages or phagocytes, and they are not able to go anywhere and cause them damage. But what is happening? Because of a variety of reasons, that these granuloma, they start inviting vessels from the periphery of the granuloma towards the center, and these vessels are leaking, these capillaries are leaking. So that when you are treating these patients or anti-TB drugs, the distribution of the drugs that you are giving to kill the MTB is uneven. So that the center of the granuloma, where there are the maximum number of bugs present, is the one where there is the least amount of drug reaching because of the leaky vessels which do not allow the exchange of these drugs with the extracellular milieu. Apart from that, there are several other mechanisms where there's the MMPs or metric metalloproteinases cause tissue destruction, the neutrophils come and cause caviation and tissue destruction, so that the MTB are able to divide, cause caviation, cause necrosis, and they keep spreading. So this is the environment which is favorable to the MTB bug and not favorable to the host as I've shown here. So what is happening here? This is a phagocyte, and I'm just showing you very briefly. I'm not going to go into very many details. When when the full phagocyte encounters an MPB, it is phagocytosed, the process, and once it is phagocytosed, it forms a phagosome. Now this phagosome gets matured, and it, normally it will fuse with the lysosomes and will form a phagolysosome. And that is the natural process by which the host phagocyte will destroy, because by releasing some of those free oxy radicals and phagolysosome, then you will have the destruction of these. Now these antigens then are presented, the main function of phagocyte is also to present the antigens in the host lymphocytes. And I'm not going to go into details of the immunology. That's how the immune process takes place. There are several other mechanisms here which try to contain. The tendency for the host cell is to contain the bug, eliminate it, and the bug has a tendency to escape these immune mechanisms by a variety of these tools that are available to the MTB. Now, how we can deal with it? How we can strengthen? Like one I told you about the vessels, and this is how we can target this granuloma structure by using anti-VEGF. Now, what we have realized that this VEGF is expressed in very high quantity in the center of the TV granuloma, and that is responsible for those leaky capillaries. Now, if you can restore the endothelial barrier, you will have the drug perfusion into the tissue, into the granuloma, more homogeneously, and will be able to target the MTB bug wherever it is located. We can also promote autophagy, another mechanism by the bug is destroyed by the phagocytes by using vitamin D3. I've told about anti-inflammatory response by using corticosteroids. There is accumulation of lipids, within the phagocytes, and statins are being tried now to eliminate those, make it rather sluggish in its activity. And then there are a variety of these mechanisms to strengthen the formation of phagolysosome. Now that is the critical, the phagolysosome formation is a critical mechanism by which the MTB is destroyed in majority of the healthy people. And if you can somehow strengthen by use some of these mechanisms. So I'm glad to tell you that ophthalmologists were the first one to use these ghost-directed therapies in the form of anti-VEGF. I'm sure you're familiar with the Western, Lucentis, IV, etc. So in 2010, in fact, Kalpana Babu from Bangalore used this therapy unknowingly while this patient was requiring the anti-VEGF and how it was working. And later on, we have reported on the use of Avastin for treating some of the very resistant granulomas, and subsequently there have been several reports now, and it is becoming currently becoming a standard of care to use, at least in the ocular tuberculosis, specifically the choroidal granulomas, the post-directed therapies in the form of Lucentis or Eylea or Avastin. But this is the first patient ever treated in the world with Avastin, and this is how you can see what I've shown you earlier, the presence of the vessels here, this large granuloma. When you do fluorescent angiography in the granuloma, you can see the internal structure is highly vascular, and this is what is visible here. So Kalpana Babu gave this patient Avastin along with anti-TB drugs, and this is more recent study by Manisha Agarwal in Delhi, Shroff Charity Hospital, where she has been doing this work, and she has reported now a large series where she has used these Avastin in these patients of TB granulomas for causing a very quick, within a matter of days, these granulomas regress once you block the VEGF with this granuloma, which I told you that the granulomas tend to express high levels of VEGF. This is one, the patient is being followed, this is the longest followed up patient perhaps in the world now, being followed for more than 15 years. And this is a patient presented, was given anti-TB drugs, was given even multi-drug resistant therapy, did not respond, and this is what you can see, the internal structure is highly vascular. This patient was ultimately given Avastin. We reported this long time back in British Medical Journal report. The patient regressed. The major challenge with these force-directed therapy is that, like, this patient remained all right, and years later, this became active again. So the vascularization came back. At this point of time, required a couple of injections at 1 month interval of Avastin for causing a regression. And this is how you can see the development. The patient becomes symptomatic because of this fluid which accumulates in the retina. This patient again showed a recurrence in 2019, and by 2020, so he's had 2-3 recurrences, each time managed with a couple of injections. So this is something remarkable which is happening now in 2020s. So to summarize, the key to diagnosing uveitis is to recognize the common clinical phenotypes, and I have shown you the expression, I have shown you the clinical phenotypes, I have shown you all the presence in the history of uveitis. We collect corroborative evidence, no doubt. Individually they may have more sensitivity, but collectively we like to gather information as much as possible. The conventional drug therapy, I've told you, has limitations. And nowadays, for pulmonary purposes, a number of trials in the last couple of years are underway for several post-directed therapies. I have just given you a brief glimpse of the kind of strategies, including doxycycline, using statins, using anti-VEGF agents, or using vitamin D3. All these are being tried to see if we strengthen the immune response of the host, whether they can deal efficiently and reduce the duration of anti-TB drugs less than 6 months. I'm glad to tell you again that we as ophthalmologists were the pioneers in the world to start using the major anti-VEGF therapy, which is a post-directed therapy, for very effectively and efficiently treating these TB granules. Thank you very much. I think I've exceeded my time limit. I'm sure Dr. Suresh will tell you soon. Thank you. Thank you very much.